Thank you very much for the introduction, and also thank you for the invitation to speak. A really important topic, given the fact that lots of exciting changes in our approach to winter wellness. So Paul and I have tried to divide this up as best we can. My focus is going to be really on flu, COVID and pneumococcus, and Paul's going to jump into RSV and clearly also some mentions about measles. So let me take control of the slides and I'm going to jump in. So before I start my talk, though, I'd like to acknowledge Wera Noongar Wudja and pay my respects to elders past, present and emerging, and thank Aboriginal contributors to the work that we do in immunisation and in health. Their input is invaluable to making sure that we have equitable outcomes for Aboriginal Australians. So this is what I'm hoping you to take away from my time is I really want you to think beyond specific vaccines and pathogens, to think about actually vaccination as a package this winter. I think we need to consider both the direct and indirect effects of vaccines, and I'm going to show you some data, particularly in the flu space, that highlights the importance of thinking about some of these indirect effects. I think we need to focus on impact. How do we actually prevent people coming to hospital rather than the numbers of efficacy and effectiveness? And a little bit of a shout out, vaccination will only get us so far. We do need to think about the impact of other infection prevention strategies, particularly for some of our high risk populations, and I'll have a couple of comments about that. But before I go into that, I think it's really worthwhile considering actually what causes respiratory tract infections, both in the Australian setting, but also internationally. I'm going to jump into these two papers just to highlight they're both US papers, but they still reflect some of the most comprehensive approach to understanding the causes of lower respiratory tract infection in adults and children. And importantly, they highlight some important trends. If you look at the adult data, clearly flu, pneumococcus and RSV are key players in the causes of respiratory infection, but importantly there's lots of other potential players that are not vaccine preventable, and many of these are seasonal pathogens, particularly with flu, pneumococcus and RSV occurring in the wintertime. If we jump into the paediatric space, a couple of things to highlight. Those pathogens are absolutely front and centre, particularly RSV, and Paul will touch on that, but importantly flu and pneumococcus being significant contributors. But I think this data highlights actually the limitations of some of these methods. When we look for pathogens, we will often find pathogens, and rhinovirus, the cause of the common cold, is detected as frequently in pneumonia cases as RSV, where we actually know that the common cold virus, rhinovirus, is an uncommon cause of lower respiratory tract infection. So we do need to interpret some of these data with a little bit of caution, and some local data that really puts that into perspective. This is a case control study that we've done out of Perth Children's Hospital, really trying to look at what we say the attributable fraction, how much of a disease is due to a specific pathogen. And you need to collect data from both those with disease but also those without disease. And it highlights in children about 1 in 5 pneumonias are due to RSV. In this plot on the far right hand side, 20.2% of pneumonia is caused by RSV, where something such as rhinovirus really causes very little pneumonia. So highlighting RSV, flu and pneumococcus are still big contributors, and they are vaccine preventable. So a bit of a summary. If you look at the data, about 1 in 2 to 1 in 4, depending on which population you look into, causes of lower respiratory tract infection are potentially preventable with vaccination. Now, this is a bit of a half glass full, half glass empty approach, but my approach is always a glass half full. If we maintain high vaccine uptake, we'll keep many West Australians out of hospital this winter, and short of some of the things we did in COVID in the early time, it is the most effective strategy we have, most effective.
Sorry, Chris, I think you've accidentally muted yourself.
Can you hear me now?
Yes, better. Thank
Okay.
you.
Can I check, did you hear me up until that most recent slide?
Probably missed the last 20 seconds.
Okay, let me just go
Yes.
back then into my summary slide. I
Sure.
apologise for those. I suppose my take is that actually about 1 in every 2 to 4 episodes of pneumonia are secondary to potentially vaccine preventable pathogens. And so I'm always a glass half full person. You know, we do need to be having vaccine conversations with everyone that we see. I've been in clinical afternoon and having a conversation with everyone I see about ways to try and keep well this winter. And short of some of the things we did during the early phases of COVID, vaccine still remains the most effective strategy that we have. So let's jump into flu. Now, many of you are aware we've had higher pre-winter levels of flu this year. We have seen summer flu over many years, but actually rates are slightly higher. So it's always uncertain what that's going to look like this year. But given that we had a moderate flu season last year, I think we do need to be fearful that this year is going to be a big flu season and prepare ourselves for that eventuality. And now's the time to really start thinking about that. Remember, flu vaccination is funded on the NIP and recommended for all young children, all older Australians, those with underlying comorbid conditions, particularly cardiovascular, respiratory and immunosuppressive conditions, all Aboriginal Australians and all pregnant people. And importantly, these are the vaccines that are available on the schedule. So many of you will have Vaxigrip and Flucelvax and Fluquadri available, and a real highlight about the importance of using the adjuvanted vaccine in the over 65 with some evidence about improved immunogenicity in that population. One of these vaccines, Flucelvax, is a cell-based as opposed to an egg-based vaccine, but there is not a preference of one over the other. Really, the thought of them having similar efficacy. So really, it's what you've got in the fridge is okay to deliver as long as it's within the age group. That is where I'd be heading. And importantly, we are using QIV vaccines this year. We may move to TIV, so trivalent influenza vaccines in the future, because the Yamagata lineage has really disappeared post-COVID, but currently we have QIV and there's absolutely no preference for egg or cell-based vaccines. Either will do. A reminder that actually the state is funding a school-based program, so for all primary school children 5 to 11, and I'll give you the background to that. And importantly, the free flu vaccine program means that all West Australians over the age of 6 months can access a vaccine either under the NIP or by the state program during those months. So there's certainly no reason why someone can't get.
You're muted again, Chris.
Not quite sure why it's doing that. I'm not touching anything, but I'm going to keep going. Please shout out when that occurs. So what is the real world effectiveness of influenza vaccines? These are moderately protective vaccines. Clearly, we'd all love a vaccine that has high efficacy, but the vaccine efficacy varies by year. In general, higher for H1N1 as opposed to H3, and higher vaccine efficacy for young children and young adults compared to older adults. So in general, vaccine efficacy is normally between about 50 and 60%. It can be as high as 70 to 80%, but some years we actually have a vaccine that's not effective, which is one of the challenges that we have with flu. To highlight the importance of the indirect effects, the study on the left-hand side is a randomized controlled trial where they vaccinated young children in the community compared to vaccinating the whole community, and they found that vaccinating young children in the community was highly effective at preventing disease in older individuals. That is because young children, particularly those in the primary schools, are the vectors of flu in the community. And the study on the right-hand side is a study that Paul and I did, really looking at what is the impact of that. And importantly, the more vaccine we can get into primary school age children, the less we do see in every age group. On the far left-hand side of the plot is if we have vaccine uptake of only 10%, but if we can get vaccine even to 40 and 50%, you can see how much less flu we have as a West Australian community, keeping people out of hospital and keeping families healthy. Unfortunately, our vaccine use, particularly flu vaccine, has continuing to slide. These are national data, all Australians on the left-hand side, Aboriginal Australians on the right-hand side, and a couple of highlights. Our rates in young children, older Australians, in fact, every age group has slipped up to 10% over the last 2 years. So dropping between 34% for the under 5s down to 25%, and high rates of 70 are now dropping into the low 60s and maybe beyond for older Australians. That trend is worse in Aboriginal Australians with lower uptake, and unfortunately is worse in West Australia compared to nationally. So we have a challenge when it comes to flu vaccine, and it's going to take a real community effort to try and get our rates back to where we need them to be. Let's jump into COVID. So this is COVID over the past 2 years, and if you squint your eyes and imagine hard enough, I think COVID is becoming a seasonal pathogen. I think we are getting to the point where we're getting increased numbers during the winter times, and as we expect, I think COVID will become a seasonal pathogen over the next couple of years. So I'm really wanting people to consider COVID vaccines as one of those winter wellness vaccines that we need to think about. I highlight this because this is the different genotypes of COVID over the last 2 years, and it highlights that COVID is continuing to evolve. The blue chunk in the middle was really the middle of 2023, where these are all Omicron strains, but the XBB strains were predominant. And then we've moved into the middle of the year where JN.1 strains are now predominant. And the reason I highlight this is our vaccines continue to evolve with this. So these are the current recommendations. So the recommendation is still for over 65 every 6 months, but there's data to show that unfortunately that message is not getting through. In those 65 to 74, recommended every 12 months at least, and those who are severely immunocompromised adults are similarly recommended at least every 12 months, but eligible even 6 monthly. What vaccines are we using? Well, they are continuing to evolve. So we now have both the JN.1 and the XBB.1.5 vaccines available for anyone over the age of 6 months. Importantly, these are all mRNA vaccines. They're all made by the one manufacturer, and although it's not really called out in the ATAGI documents, there is a preference for JN.1 if you can access it, but importantly the difference is not really large, so any vaccine will be sufficient. But if you had a JN.1 in the fridge is what I would be using on a patient that was before me, if something else, if that was what was available to me. What is the effectiveness of COVID vaccines? Well, COVID vaccines are effective in the populations we're wanting to protect. So these are vaccine efficacy estimates from a reasonably large Dutch study looking at the impact against hospitalizations and ICU admissions in older individuals, showing vaccine effectiveness above 60 to 70% in this age group. The challenge with COVID vaccines is that continues to wane, and so this is not long-lasting protection, unfortunately, but given this is the age population that is coming into hospital with COVID, that short-term protection is likely to make a significant benefit to public health. Unfortunately, that message is not getting through to community. These are the current vaccine uptake rates, and even if you look at the last 12 months, over the age of 75, less than 40% have had a vaccine, and even in aged care, clearly a population at significant risk of COVID, vaccine uptake is only 70%. So I am encouraging providers to have a COVID vaccine conversation as part of the winter wellness conversation, to at least get a vaccine in every 12 months, I think would make a significant improvement in our current coverage. A little plug for pneumococcal disease, because pneumococcal disease remains a challenge. The vaccine program is always complex and confusing, but unfortunately under vaccination in this space continues to occur. Little step back, pneumococcus significant decrease during the COVID times, but has come back with similar rates in the pre-COVID time, and it's the young and the elderly who are most at risk of pneumococcus. But unfortunately, we are not good at diagnosing pneumococcal cap, so pneumonia. Most of our estimates come from invasive pneumococcal disease. Our recommendations are for a 13-valent conjugate vaccines. That's the one that's on the routine schedule for infants, using a 2+1 schedule, so 2, 4 months and 12 months. An extra dose is given to medically at risk in Aboriginal children in Western Australia, so the 6-month dose is given there. And importantly, this is the vaccine that's recommended for all medically at risk children and adults, all Aboriginal adults over the age of 50 and all non-Aboriginal adults over the age of 70. So recommended for at least 1 dose. And 23-valent is still recommended as a booster for some of those populations. But the reason I flag is I expect this to change over the next 12 months. So medically at-risk children, Aboriginal children, medically at-risk adults and older Aboriginal adults can access up to 2 doses of 23-valent pneumococcal vaccine. I put up my next slide to highlight actually things are changing. There is a 15-valent vaccine and a 20-valent vaccine available, but not on the NIP. And what these are doing is they're adding additional serotypes. So of the 90 different pneumococcal serotypes, Vaxneuvance has 15 of them, Prevnar 20 has 20 of them, and things are only getting more complicated with 21-valent, 24-valent, 31-valent coming as well. There is some interesting technology here, and I draw your eyes to the second one, which is a 21-valent, which has been specifically designed for adults to complement the pediatric vaccine with really the protection, different serotypes included in that specifically for that purpose. Are these vaccines effective? Well, they are effective. So these are data against invasive pneumococcal disease from systematic review in trials against vaccine type invasive pneumococcal disease. A 13-valent vaccine is effective about 75% of the time, and in observational studies, similar sort of numbers. Slightly less effective against vaccine type pneumonia, and in all the studies, significantly more effective than 23-valent. A little shout out, so the vaccine schedule changed in 2018 from the 3 infant doses without a second year of life booster to the 2+1, so 2 infant doses and a second year of life booster. And this is recent work that we've demonstrated that actually the impact on that was significant. The plot on the bottom right is the modelled estimates of IPD in this age group if we hadn't changed the protocol to what we have observed. So that change in pneumococcal schedule has prevented significant numbers of invasive pneumococcal disease over the last couple of years. The problem in my mind is the message is not getting through. Pneumococcus is a complicated program, and this is uptake of the adult recommendation in different states. And as you can see, less than 40% of Aboriginal and non-Aboriginal West Australian adults who are eligible have had a dose of 13-valent vaccine. So we're not using the 13-valent vaccine as well as we could, and particularly if we move to extended valent vaccines, we do need to make sure that this is part of our winter wellness strategy as well, making sure they have had a pneumococcal vaccine. And so with that, I'm going to really hand across to Paul, but I suppose what I wanted to highlight is I think vaccination is a package. It's a winter wellness package that now should include flu, COVID, pneumococcus and other vaccines. So in other words, we should be talking to our patients about the importance of these vaccines. We should be co-administering these vaccines, particularly in the pre-winter stage. We should be reviewing the immunisation status, particularly for our higher risk individuals, including our older Australians, every year, and the pre-winter time is the obvious time. And also at the same time having the conversation with some of these individuals about strategies to avoid respiratory virus exposure, staying at home when they're sick. You know, if they're a high-risk individual, they may want to use a mask in public. Some of these simple things we learned in COVID are as relevant now for particularly our high-risk patients as they were beforehand. And so with that, I'll stop and stop sharing and hand across to Paul.
So today I'm going to talk about RSV and then a little bit about measles because it's in the news and I think it would be useful for people to get an understanding of where we are. But let's go first with RSV. And I want to talk about what we achieved in 2024 in case you haven't heard, and then what's new for 2025 and what I hope we can do in 2025 to build on that success. Real briefly, just to say that RSV is the leading cause of infant hospitalization in Australia. About 2/3 of kids get infected in their first year of life. In WA, we have data that says about 1 in every 25 infants are hospitalized with RSV each year. And we talk a lot about the hospitalizations, but this is really a pyramid of disease and hospitalizations sit close to the top. There's obviously a lot of emergency department visits, GP consultations, and symptomatic cases that don't end up seeking care. So really, though, when we speak about hospitalizations, we're really talking about a spectrum of illness in the community. So as you might recall, our program from last year, we were the first and largest age-eligible program in Australia. We offered the RSV nirsevimab, the monoclonal antibody. We're using the term Beyfortus now because we're using a vaccine and using the brand name, so we switched to calling it Beyfortus, our nirsevimab program. But it was essentially 4 groups of kids, a catch-up cohort of kids born from October of the season prior to RSV and going all the way up through RSV season. That was our second cohort, those kids born May through September, which is RSV season in most of the state. And then we have kids with medical risk conditions, and Aboriginal children were eligible to get it if they were entering their second RSV season. So those 4 groups were our target. And how did we do? Well, we'll talk about coverage. We administered just over 24,000 doses of Beyfortus to individuals in the state, and that was done by more than 1,000 different providers. This is data taken from AIR. So a fantastic effort in numbers. That was done by general practitioners, hospital midwives and nurses, giving it to children before they left the hospital after birth, our community health nurses and our Aboriginal health services. You'll see pharmacists aren't on this because they're not able to vaccinate infants, and this is an infant program or second year of life program solely. So really good spread across the different healthcare provider sets. And what we get for coverage with that? Well, in the catch-up cohort, and that's those kids that are born from October onward before RSV season starts, it was about 66% coverage, which was really good, I thought, for a first year of a program and a brand new product to Australia. And in our newborn cohort, it was even better, as you can imagine, because all those children are captured in hospital, and then very quickly after that, usually at a GP visit or community health visit. And so it was close to 80% coverage. Again, fantastic work on a part of all the providers, some of you on the call today, I'm sure. Well, how well did it work? Well, there you'll see young Chris Blyth again. He and his PhD candidate, Dr. Ujma Wadia, have been the drivers of a test negative control study done at a Perth Children's Hospital and some other metro hospitals here. And the punchline of that is that if you received Beyfortus as a child, as an infant, it was 88% protective against being hospitalized with RSV. So a phenomenal result, not inconsistent with what we're seeing from around the world in other settings, but still really effective in individuals that received it. But I'm a public health doctor, and we really look at things on a population-based level. So my question was, what did it do for our communities as a whole, and potentially for our health service? And so for that, we look to impact. And this graph here is looking at kids that are older than the cohort that normally would be eligible for nirsevimab in large, so 1 to 5-year-olds. And it's presenting the hospitalizations there for RSV, the cumulative hospitalizations for the 2 years prior. You see 2022 in green and 2023 in blue. And you can see that how they just march up as winter comes along. And if we look at what happened then this year, in 2024, we actually had a big RSV season in children. It was more hospitalizations for RSV in the cohorts that were not eligible, by and large, to receive nirsevimab. So a heavy RSV season. Well, what about the infants, the real target, real focus of our nirsevimab program? Again, this is the data for the prior 2 years, and you can see, before we introduced nirsevimab, that cumulative cases just go ahead and rise there up to about 1,000 hospitalizations each year in infants under 1. And then this is what happened this year after our nirsevimab program was put in place in April, and it's quite a big reduction in the number of hospitalizations in infants. And we can actually quantify what that reduction was. So I'm going to just show, we've done some math to look at the hospitalizations prevented. And the first method we use just takes an average of the prior 2 seasons of what the hospitalizations, and then subtracts what we saw actually. And so it looks like we prevented 505 hospitalizations in infants last year using that method. And at about $14,000 for each hospitalization, that's almost $7 million in savings. But another method actually takes into account how heavy the RSV season was. It won't go into the details here, but using that method, it looks like we would have prevented 677 hospitalizations in infants last year. And that comes out to about $9 million in savings. And again, I'm less concerned about the savings and more concerned about keeping infants out of the hospital so they might not be predisposed to asthma later in life, and sparing the families the stress of that. But it's a phenomenal result. Whatever number you pick, you'll see the 505 number pretty soon published in the Medical Journal of Australia. We went with the conservative route, trying not to overplay it. But my suspicion is that it was somewhere between 500 and 665 hospitalizations prevented because of the work you all did in getting infants their Beyfortus. Well, now we come into 2025, and we have 2 options, and both of them involve providing the infant with preformed antibodies that can inactivate RSV virus when the infant gets exposed to it. And one of them does that this is a Brisvo, which is a maternal vaccination. And with a Brisvo, you vaccinate the mother during their pregnancy. The mother then makes RSV specific antibodies that are passed through the placenta to the developing child in utero. And this can provide protection for up to 6 months after the baby's born. Our other option is the one we had last year, which is given the monoclonal antibody that's made in a laboratory, and you basically provide it to the infant at birth or to the young child just before RSV season starts. And we know there's good evidence to show it lasts for at least 5 months, in our experience. In WA last year would suggest that protection is actually longer than 5 months. So I'm just going to spend a little bit more time on a Brisvo because it's the new kid on the block. This maternal vaccination is being provided free through the NIP for pregnant women beginning at 28 weeks. How well does it work? Well, in the clinical trials, it was 57% effective against preventing RSV hospitalization up to 6 months, and it was more effective against severe disease, more like 70% effective at preventing severe lower respiratory tract infection in the first 6 months of life. How long does protection last? Well, it lasts 6 months. Essentially, maternal antibodies for whatever their pathogen they're against, be it pertussis or varicella, they ultimately degrade in the child and are usually not able to provide protection out beyond 6 months. But that's the time when the infant is most vulnerable. So it's really opportune for protecting them. How many doses of Abrysvo do pregnant women need? One. A single dose is all that's needed to provide the child with protection. When should women get it? As I mentioned, beginning at 28 weeks, 28 to 36 weeks is the sweet spot. If a woman's not vaccinated before 36 weeks, they can get it as soon as possible after that time. However, if they deliver within 2 weeks of receiving the Abrysvo vaccine, we would not consider that there'd been enough time for the mom to make antibodies and transfer enough of them to the child to protect them. So this is my graphic of that. When should pregnant women get Abrysvo? I condensed the first few weeks, but essentially in weeks 1 to 23, don't go there. The product's not registered for vaccinating women that early in pregnancy. From 24 to 27 weeks, it is registered, but not recommended because it's not ideal. But from 28 to 36 weeks, that's the sweet spot, and we want to aim for that. But you can certainly do it later than that. It's our second best option if they missed out on the earlier period. But as I mentioned, we got to have 2 weeks between the jab and the birth of the baby to be sure that the baby's got enough protection from the Abrysvo. Does Abrysvo need to be administered twice if it was given earlier in pregnancy before 28 weeks? No. If a woman's gotten a dose of Abrysvo, we will consider that it works at any time when it's given, but we'd like to follow the regulatory guidance. Can Abrysvo be co-administered with the other maternal vaccinations that are recommended? Absolutely. Can be administered with pertussis, influenza, COVID-19 vaccines, and there's been no safety concerns identified from co-administration. Where can pregnant women access Abrysvo? You can get it at birthing hospitals, general practices, community public health clinics, Aboriginal medical services, and this one I will emphasize community pharmacies, because community pharmacies have a role now in prevention of RSV in infants, since they are able to provide Abrysvo to pregnant women. And this year so far, where are pregnant women getting their Abrysvo? This is a screenshot I took this morning of our dashboard that pulls data out of AIR. And you can see GP practices have administered about 50% of the Abrysvo maternal vaccinations so far, with hospitals with 20%. And you can see pharmacies in there with 15% or more than 500 jabs. So quite a good team effort in getting women protected. And how's our uptake going with those numbers? Well, this is crude math, but if we say we have 31,000 births a year, which is about right, or close to 600 births a week, we are administering, according to AIR data, about 360 Abrysvo doses each week, so about 60% coverage. And I'm pretty pleased with that because that's about where we are with more long-standing vaccines like pertussis coming out. It may be a little bit lower because when Abrysvo was first launched on February 3rd, there was a large cohort of women who were eligible because they were eligible from 28 weeks through the end of pregnancy, really. And so we made these numbers, the denominator may be a little bit bigger than this, but it's somewhere between 50 and 60%. So a strong effort. But that still means there's some kids who aren't being protected. So women that are breastfeeding, should they get an Abrysvo vaccination? No, not that it would be harmful, but it won't be able to protect the infant because there's not enough of the antibody transferred through breast milk to do that. And there's therefore no reason. We're not actually vaccinating the woman to protect her. We're doing it to protect the infant when they're at risk. And so therefore, breastfeeding without pregnancy is not an indication. So what are the contraindications? Only anaphylaxis after a previous dose or a component of the vaccine. Since we haven't used it before, that's not going to be a contraindication this year. Can Arexvy, the other RSV vaccine that's registered for older people, can that be used to vaccinate pregnant women? Well, no, that's a hard no. It's not registered for pregnant women, and we don't want to go there. But if a woman happens to get Arexvy, you do not need to give Abrysvo as well. We will assume that the protection provided by the non-registered product is sufficient. Can infants be given Abrysvo or Arexvy instead of the monoclonal antibody Beyfortus? Can we give them the vaccine? No, neither of neither one of these vaccines is registered for use in children, and we should be clear that we do not want to give children a vaccine for which it's not registered. So that's Abrysvo. I'll go to option B, which is Beyfortus. As you know, it's registered by the TGA for neonates and infants born or entering their first RSV season, and for children up to 24 months who remain vulnerable to severe disease through their second RSV season. And with Chris and other pediatricians' help, we decided that group was going to be Aboriginal children because of the high rates of hospitalization from RSV in that group, and kids entering their second RSV season, and certain medical risk factors, which I will get to in a second. So I'll be brief on Beyfortus because we've used quite a bit of it and you're familiar with it. But the only contraindication to Beyfortus is a serious allergic reaction to a previous dose. After 24,000 plus doses administered last year, we did not see that in our cohort in WA. So I'm thinking that will be rare. Beyfortus can certainly be given with the other childhood immunizations. It's not a vaccine, and it's not expected to interfere with the vaccines that would be given at birth with hepatitis B or the others given at 2, 4, and 6 months of age. The protection we mentioned, it lasts 5 months. At least 5 months, that will probably be the best protection. So that makes the best time to give Beyfortus just prior to RSV season. Right, so you can catch up all those kids that were born from October, through the Christmas holidays. We can give them Beyfortus in April and May, and protect them during the upcoming RSV season. And then we can continue to give Beyfortus to children that are being born during RSV season, May through September. And I'm speaking about most of the state. We have a little bit different guidance for the Kimberley and Pilbara, where we assume RSV season continues throughout the year. So who should get it in 2025? It's gotten more complicated because if your mom's received an Abrysvo vaccination, you don't generally need Beyfortus, and there are some exceptions where I'm going to talk about it. So it's changed. Instead of like all young children are eligible for Beyfortus, or I should say all infants and some entering the second year, now we have to know the mother's vaccination status to make the right call if we can. So I'm going to present this as a pyramid. So sort of like what is the biggest cohort that's going to need Beyfortus in 2025? Well, it's basically the biggest cohort is going to be the catch-up. And that's the mom wasn't eligible for Abrysvo because the child was born before we started the program in October, November, December. So it's basically about 12,000 infants are still in that category coming into their first RSV season that we want to protect with Beyfortus like we did last year. Second is going to be all the children whose moms were eligible to receive Abrysvo, but they didn't receive it for whatever reason. And right now it looks like that math, it might be 40% of the cohort, if 60% are being immunized or vaccinated and maternally, that's fantastic, but it still leaves 40% or maybe 10,000 kids by the time we get to September 30th who could benefit from protection with Beyfortus. And then the other caveats are if the mom got Abrysvo but delivered within 2 weeks, well, that's going to be a tiny group, but we need to consider that and make sure we cover off those kids. If the mom got Abrysvo but she was immunocompromised, well, again, that's going to be a tiny group, but we would still give that child Beyfortus because the mom probably didn't make enough antibodies. Or if the mom got Abrysvo but had a treatment that removed her antibodies, again, that's going to be a tiny group. But if you knew about it, if it was evident, you would still protect that child with Beyfortus. And then if the infant is born, and this is probably more important, numerically at least, infant born with serious medical condition, we will still recommend giving that child Beyfortus, even if the mom got a maternal vaccination, because essentially we're going to use a belt and suspenders approach and try and make sure they're covered by both ways. And then, of course, maternal vaccination won't do it, since it only lasts 6 months, won't provide any protection to those at-risk kids entering their second season, which is Aboriginal children and children with serious medical conditions. And I said I would mention those, what they are: preterm birth below 32 weeks, significant congenital heart disease, significant immunosuppression, chronic lung disease requiring ongoing oxygen or respiratory support, neurologic conditions that impair respiratory function, cystic fibrosis, and trisomy 21. So this will be fairly rare. The children that still need Beyfortus if the mom was vaccinated with a Brisvo, or that need it going into the second year of life. But that is the categories. So now that we have two options for preventing RSV, we should do even better than last year, right? Well, I have concerns, and that's why I'm really plugging this, because I think there's some risk. There's diffuse responsibility across multiple providers now, and pharmacists are involved, which is fantastic because they'll be able to reach pregnant women that might somehow have fallen through the cracks other ways. But it means that the medical record keeping, we need to make sure those Brisvo doses are making it to air so that the other clinicians that might see the child later can make the right call. I'm worried that providers seeing an infant might erroneously assume that the mother had been vaccinated with a Brisvo and therefore not give Beyfortus to the child, which would be a missed opportunity. I'm worried that the provider might not know if the mother had received a Brisvo, because mothers might not remember which jabs they received, to be honest, and might be worried about giving Beyfortus, thinking, oh, what if the mom's already been vaccinated and I give it Beyfortus? Is that a problem? Well, it's not a problem medically, because in fact, as I mentioned, if the child has certain medical conditions, even if the mom's vaccinated, we want them to get Beyfortus. So it's not a medical issue about giving the child Beyfortus if the mother received maternal vaccination. It's probably unnecessary unless the kid is high risk, but you won't be doing harm. And I'm worried that the catch-up cohort might be overlooked as we orient ourselves to maternal vaccination in infants, which is good, but I just don't want to have that catch-up cohort that can't benefit from maternal vaccination be left out of the conversation in Western Australia. With that, I'm going to jump to measles real quickly, just a few slides on that. If you go to our website, you can see our notifiable disease data pop up live. This is for measles, and you can see that we've had a spike in cases down there on the end in the last couple of weeks. So 13 cases year to date, 12 since the 19th of March in two clusters, one of them small, which was an imported case, and then a secondary case that was exposed in a GP waiting room. And I mentioned that to remind clinicians about the need to make sure your staff are protected. And that unknown index case linked to 10 other cases. 6 of them are in the prison system. One of those individuals had contact with the Bunbury Hospital and resulted in several infections through exposures in a hospital setting. Again, emphasizing the need to make sure all healthcare providers are immune to measles. You know, measles makes people sick, and sick people go to doctors and hospitals, and so it's no surprise that there's emphasis there. Well, measles vaccine, one dose is about 93% effective. You hear 95 as well, but I think 93 is probably closer. 2 doses of MMR vaccine is about 97% effective. So that's what we want to do to make sure we don't have ongoing measles transmission in WA. So who's most at risk? Well, we start vaccination at 12 months of age. And the 2-dose MMR schedule started in 1994 because you really want those 2 doses to be up around 97% protection. And measles circulated widely up through 1965 in Australia. So that tells us who's most at risk. Kids that are under 1 that haven't received a dose of vaccine, they're at risk. People greater than 30, because we started this 2-dose schedule in 1994, there will be a bunch of people older than 30 that only have 1 dose. And therefore won't have as good a protection. And then those people, under 60, because people 60 and over at this point in time probably had natural infection. So again, this age group, young adults and adults, tend to be those that are in prison and tend to be those that work in healthcare. So our priority targets are obviously children. We want to maintain our great rates in children to prevent transmission in that cohort. We need to make sure our healthcare workers are protected because they're most likely to get exposed. We need to prevent the introduction of measles from overseas where it circulates. You know, Australia has been measles free since 2014 for a decade, but we still get introduction. So we want to make sure our travelers are covered. And of course, it makes sense because of the exposure potential in prisons that we would want to make sure prisoners are protected as well, but we'll leave that to the Prison Health Service. So how can we get this cohort of 30 to 60-year-olds protected? Well, we have a program, and we've had it for many years, that provides measles, a state-funded program, provides adult measles vaccine for free for anyone born from after 1965 that doesn't have documentation of 2 doses. You can receive that vaccine, and you can receive it at multiple sites, including pharmacies. I just want to remind people, though, that MMR vaccine is not recommended for pregnancy. So, and that's also in this 30 to 60-year-old group. So we would just want to keep that caveat in mind, or immunosuppressed individuals. But everyone else, we should really be trying to make sure gets protected. So my take-home messages for today: offer Brisvo to all pregnant women at 28 weeks. Offer Beyfortus to all infants born before Brisvo program started. All infants born since February where the mother was not vaccinated, and I say effectively, you know, those little caveats, immunosuppressed and or delivered too quickly after they were vaccinated. All babies with high-risk conditions, regardless of the mom's vaccination status, those high-risk conditions that I showed. All Aboriginal and children with high-risk conditions entering their 2nd season should get Beyfortus. And lastly, offer MMR to anyone age 60 or under without 2 documented MMR doses, and especially target healthcare workers because of their risk, and travelers because they're also at risk of getting it themselves and then bringing it back to Australia. Thank you very much.